Hi, this is Elliot Fishman, and welcome to the April 2026 CTisus quiz. I have 10 excellent cases to share with you, so let's get started. In this patient with B-cell lymphoma and abdominal pain, the best diagnosis is, well, if you look, there's ascites, but what's most impressive is the colonic wall thickening, particularly near the splenic flexure and descending colon. It could be ischemic colitis, but I don't see any vessel occlusion. Lymphoma can involve the colon directly, but that's rare, and it's usually more likely the cecum. Neutropenic colitis is usually, again, the cecum and terminal ileum, typically referred to as typhlitis. When you have wall thickening, be it focal or diffuse, particularly when it's impressive like this and it's a patient who's likely on antibiotic therapy recently or even currently, the best diagnosis is pseudomembranous colitis. Again, it's not specific, but I would say the patient has colitis, and I would be concerned about pseudomembranous colitis, and they could do lab tests to prove this. The most likely diagnosis in this 30-ish-year-old female is, well, when you look at the lung fields, you see multiple cysts bilaterally. There's no pneumothorax, there's no adenopathy. This is not emphysema because it's multiple specific cysts that are all about the same size and shape and involve the entire lung. It's not prior pulmonary emboli with some lung injury, that's more focal. It's not the appearance of prior lung transplant rejection. This is a classic example of LAM, lymphangiomyomatosis. Classic has cystic spaces in the lung that usually involve from the apex to the bases. Just a very nice example. The most likely diagnosis in this patient with groin pain was, well, when you look at these two cinematic rendered vascular mapping, there are multiple lobulations off the femoral artery. This is not the look of septic emboli, but these patients probably do have septic emboli. It's not a dissection of the femoral artery. It's not classic vasculitis, which shows wall thickening and narrowing of the lumen. This is a pseudoaneurysm, likely a mycotic pseudoaneurysm. This is a great location in a patient with IV drug abuse to develop mycotic pseudoaneurysms. A really nice example, and the role of cinematic rendering is very nicely shown. The most likely diagnosis in this patient with fever and weight loss is, well, there's a large splenic lesion. It's not going to be sarcoid. Those lesions are smaller and multiple. This could be a large splenic abscess. I don't see anything else in the abdomen. So splenic abscess is a thought. The truth is it could be lymphoma. Weight loss, fever is great for lymphoma. Angiosarcomas are usually hypervascular. This is cystic, and so I would tend to favor lymphoma. Couldn't exclude an abscess. Believe it or not, this patient had a splenectomy, and this was an angiosarcoma. And I'm showing you this case because I got it wrong, and you'll get it wrong, because splenic angiosarcomas are typically solitary or multiple vascular lesions, often irregular in the spleen. With splenic angiosarcomas, you may also see hepatic involvement. So an unusual case with an unusual appearance. In this 20-ish-year-old with a recent motor vehicle accident, the best diagnosis is, well, you see a lesion in the pancreatic head. This is not related to trauma. Yes, it could be a pseudocyst, but there's slight irregularity of the wall. It doesn't have the really good definition I like to see in a pseudocyst. And how many times am I going to show you a pseudocyst? It could be a serous cystadenoma. They can be small, can occur in the pancreatic head, have a range of appearances. Definitely could be an IPMN, though the borders are a bit irregular, but it can be an IPMN, and then you would worry, could there be any dysplasia? And a mucinous cystic neoplasm is more likely in the body of the pancreas, and it's usually in a 40-year-old. Now, serous cystadenomas are usually in 60-year-olds, so that's not very helpful. This eventually had EUS, and this was a serous cystadenoma. It shows you the spectrum of serous cystadenomas. We think of them as larger, but they can be smaller. They can have calcification. This does not. And so it can be a challenging, as always, diagnosis. The most likely diagnosis in this patient with flank pain is large mass left adrenal gland. It doesn't have the look of classic hemorrhage. Could it be an adenoma? We've seen atypical adenomas, but I would never call this an adenoma. Pheochromocytomas are usually vascular. When I see a mass like this, which is about 6 centimeters, I'm concerned that this is a primary adrenal cortical carcinoma. That's my favorite diagnosis. And this, in fact, was a primary adrenal cortical carcinoma. The least likely diagnosis in this case, well, I see a large anterior mediastinal mass which is infiltrating. My first guess would be lymphoma, and then I would think about maybe a thymoma, and then I would also throw in there teratoma. This does not have the look of a substernal thyroid. This, in fact, was lymphoma. It was a B-cell lymphoma infiltrating the mediastinum, and the least likely diagnosis is a substernal thyroid. In this patient with hematuria, the best diagnosis is, well, when you look at the patient's kidney, there's an infiltrating tumor. Now, I'm showing you only 2 images. They're both venous phase. This could be a papillary renal cell carcinoma. I can't exclude that. It's likely not a clear cell because it's not very vascular. And lymphoma can be solid masses, but usually they're solid and not somewhat infiltrating like this, and they're larger. But I could not 100% exclude that possibility. In this case, it's infiltrating, and I wonder if we're dealing with a transitional cell carcinoma. On the coronal views, it does appear to go toward the pelvis, and so the best answer is transitional cell carcinoma. I think you would do better in this case if you had excretory phase imaging. So I showed these images to make the point that on excretory phase imaging, you'll probably see deformity of the calyces, which indeed was present, and you would have been easier to make the right diagnosis. The most likely diagnosis in this case was, well, we see a large mass, coarse calcifications, cystic and solid components. The mass is over 10 centimeters. This is not the look of a pseudocyst, and it's surely not the look of an IPMN. Mucinocystic neoplasms can be large. They have calcification, but they're more cystic and have septations. And if it was this large, it would be a malignancy, and you might see some nodularity in the wall. This is more of a classic serous cystadenoma. Large, complex cystic lesion with septations and central calcifications. Just a classic serous cystadenoma. The most likely diagnosis in this case, well, in the body of the pancreas is about a 1 centimeter vascular lesion. In most patients, I would look at this and say neuroendocrine tumor. But if you look, there's clips by the left renal bed, and the pancreas falls posteriorly, as does the stomach, because the patient had a left nephrectomy and splenectomy. So this is not a vascular malformation. It's not a hemangioma. This is a classic example of metastatic renal cell carcinoma to the pancreas. Mets to the pancreas, the most common source will be renal cell carcinoma. They can be solitary or multiple. They can be small or can be large. And it's classically from a clear cell renal cell carcinoma. If you only look at the lesion itself and disregard the kidneys, it's almost impossible at times to distinguish a neuroendocrine tumor from a metastatic renal cell carcinoma. So a very nice case. Anyway, those were 10 really nice cases. I hope you find them helpful, and I hope you looked at them very carefully and learned something. And with that, I'll see you next month. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.